talk recently about seniors housing companies getting into the risk-taking business, or better put, having a stake in the payment for services for the elderly and sharing in the profit risk. It is a confusing topic, partly because it is so new and partly because it is so fluid. Hell, I am far from an expert, and I'll probably make a few misstatements here. Probably already have. 2 years ago, it was all accountable care organizations, or ACOs, for skilled nursing facilities, where they could share in any Medicare cost savings by working more closely with hospitals and other providers. Well, in many cases, the hospitals started bypassing the SNFs, figuring they could save even more money if the patients were discharged directly to their homes instead of an inpatient facility. Sometimes that works, other times it doesn't. But many skilled nursing facilities have been left high and dry. And 20 years ago, we were introduced to capitation, whereby a skilled nursing company, or maybe a group of its facilities in a region, could receive a fixed payment for a certain pool of people. If they showed up in their skilled nursing facility, they would take care of them. The joke at the time was that they would make the most money if those beds were empty. Some investors had a hard time comprehending that because you make money by being paid to take care of your patients and send them home. Under capitation, you make money if there are no patients to take care of because you have already been paid in advance. Each admission thus becomes an expense item. Unfortunately, in skilled nursing capitation, it didn't go very well. It wasn't widespread in use and didn't last very long. As everyone knows by now, Medicare Advantage plans have been putting the screws to skilled nursing facilities in 3 primary ways. They have scrutinized how long it really is medically necessary for the patient to remain in the SNF and cutting back lengths of stay. They have been ratcheting down the daily rate for that patient, and they have been making decisions as to whether that patient really needs institutional care or can be treated just as well from home or in assisted living. All of these have cut into revenues and profits. Here is an interesting fact that I recently learned, at least I think it is fact. The financial profile, apparently, between those people turning 65 who join a Medicare Advantage plan as opposed to opting for traditional Medicare is quite different. Medicare Advantage plans are cheaper than traditional Medicare, and they offer a bunch of free things or discounted things, such as hearing aids, vision care, and others I've not heard of. But those two are key, apparently. From what I've heard, it is a more middle or lower income group that chooses Medicare Advantage plans, while the more upper income people turning 65 choose traditional Medicare because they have fewer money worries and don't get excited about the freebies. They may also understand that they will no longer be dealing with the insurance companies that have a habit of saying no, no, and no. Traditional Medicare just pays the bills, from what I hear, but I will know soon enough. We've all read about how a vast number of the baby boomers are not financially prepared for retirement, have little savings or plans for paying for their health care or long-term care, and will be a burden on society and their own children for years to come. Quite possibly true. But they will also be a burden on the seniors housing and care industry, even though everyone seems to view them as the solution to all our problems. If they don't have the money, they will not be the solution. I say burden because very few people are building for this less affluent segment of the elderly population. What is beginning to happen, although slowly, is that Medicare Advantage plans are already getting involved with seniors housing. Even though they will publicly tell you they want the best outcomes for their members, what they also want is the lowest cost to take care of their members. If it is cost beneficial to pay for one of their members to be in assisted living with better supervision, better dietary plans, and more socialization, and this keeps them out of the hospital, in the long term, the Medicare Advantage plan wins, and presumably the resident wins as well. The movement, currently in its infancy, is to have seniors housing providers get proactive in Medicare Advantage, either by grouping together and forming their own plan, or partnering with a plan and having some real influence on the decision-making and care plans. While perhaps risky, the argument is that with this vast baby boomer group that will eventually be coming into seniors housing pipeline, many will be enrolled in Medicare Advantage plans, If I am right, they will not be the wealthier ones who are currently the target of the industry. So, I think the theory goes, as these Medicare Advantage plans grow in popularity, and they are growing at a faster rate than traditional Medicare, their influence in seniors' housing will also grow. After all, some people say assisted living is the old nursing home, but in terms of frailty, not physical appearance. So why wouldn't their influence grow in seniors' housing like it did in skilled nursing facilities? Instead of being dictated to, like the Medicare Advantage plans are doing to SNFs today, be at the table and profit from it, the argument goes. Of course, there are differences of opinion about this, and personally, while I understand where they are coming from, I also wonder if we are still too early in the cycle. But as the old saying goes, the early bird catches the worm. I'm sure there'll be a lot of wiggling in the next several years to come.